Okay, the patients that are at highest risk for developing advanced forms of cutaneous squamous cell carcinoma would be those where prior surgeries had failed, so 2 or more prior surgeries. Those where the biopsies show perineural invasion, especially nerves that are greater than 0.1 millimeter or named nerves. Those with the subtype of histology being moderately to poorly or poorly differentiated, so those are more aggressive cancers. Those where the width of the tumor is 2 centimeters or larger, and those where the invasion depth on histology is 2 millimeters or greater. The workup for advanced squamous cell carcinoma, of course, depends on the specific problem at hand. If you know you have perineural invasion, the thought is that MRI is a better tool to look at the extent of perineural invasion, which is often a big determinant on how serious the disease is and also what treatment options are available. For perineural disease, MRI is a better modality. Picks up the perineural disease extent better. Patients may have a hard time holding still for a slow study like an MRI, and they may have the artifact that the patient can't remain still. CT is a generally faster study with a more uniform accuracy because it's not dependent on whether the patient can remain still. Certain tissues show up better in MRI, certain tissues show up better with CT. It's a judgment depending on the biopsy results and the location of the tumor. So let's talk about how to communicate the extent of disease and the areas of involvement. My preferred way to look at this is the way the studies are designed, and that's either having contiguous disease, which would be your locally advanced subdivision of advanced, or metastatic, which is your discontiguous subdivision of the term advanced. When we have discontiguous disease, otherwise known as metastatic disease, that can be locoregional, such as neck nodes or parotid nodes, or distant, such as organ involvement or bony involvement. And I prefer to think about this disease as either contiguous or discontiguous disease, i.e. locally advanced versus metastatic disease. The staging criteria, the AJCC, is a work in progress. We went from 7 to 8 in an attempt to try and improve it. The outcome of the changes has not had time to be measured yet, to be assessed. So we don't know if the AJCC 8 correlates with known outcomes from treatment of disease. I like the Brigham and Women's staging criteria because it attempts to incorporate as many different risk factors, features in staging. And we went through some of these already, such as the 2 millimeters or greater depth, 2 centimeters or greater width, the poorly differentiated tumor, the perineural tumor. So we don't know yet how well AJCC 8 will perform. I like Brigham and Women's, but if I had to choose, I would stick with the way the studies are designed, which would be locally advanced or metastatic disease. It's more important for a TNM or disease stage if you're trying to communicate for surgery and or radiation, in my opinion, than it is for systemic therapy, especially immunotherapy. And in that case, again, I'd rather have locally advanced or metastatic as my assessment of the disease.